Health promotion concepts and priorities is the title for today. Not many slides, but what we will be covering are some general concepts of various types of health promotion. Trying to join the dots between the determinants of health and health promotion, and determinants of health that you're already familiar with from earlier on. And then looking at some specific health promoting interventions that you might want to choose for your assignment, because some of the feedback we've had in previous years is there is so much that I could write about. There are so many possibilities for health promotion. If I look at the determinants of health, where do I start? Yeah. So we'll hopefully unpack that for you a little bit today, and we might even get out a little early. So generally, and just by way of revision from last week, the health promoting way of working involves working with the community, finding out what the community's priorities are, not what we think is important. It's interesting, in the first assignment, one of the common mistakes that's made in response to that question, how do you have a conversation with somebody who has different beliefs to you? A common mistake, and I'm not looking at anybody in particular, is convince them that they're wrong. You don't do that. You need to find out what the community or what the patient's priorities are. You may disagree with them vehemently, but the patient's priorities are what the patient's priorities are. And we work with them. If there is change, it will come from the patient. And there's a process around that. But people do not change by being browbeaten. Yeah? I mean, you know from your own experience, who's ever changed what you've done because you've got into trouble for doing it? Maybe reluctantly, but your heart wasn't in it, okay? You put the toy down because you got into trouble, not because you wanted to put the toy down. All right, supporting local initiatives, helping communities, people help themselves. This is what health promotion is all about. We need to find out what is already happening. So a needs assessment involves a mapping and getting a sense of what is happening in the community around this issue that you're exploring. Find out what people already know, why they think is important, is why we had the first assignment on health beliefs. It may be that some of you write your health promotion project based on one of those three that you did the health beliefs reflection on, and that's okay. An aspect of that. Share information. There might be some gaps in the person's knowledge base. They may say, look, I don't know, or they may not know what they don't know. There might be unknown unknowns, to use the vernacular. There may be skills that need to be developed that you identify, or that the people themselves identify. I don't know how to do this. So anything that talks about doing something implies a deficit of skills. There might be data that we need. We might not have all the information we need, so there might be some research that needs to be done in there. There may be some community action required, or there may be extra resources that the community needs in terms of funding, infrastructure, policy support, and so on. So concepts of health promotion, the dominant one, I suppose, has always been, for a long time, biomedical. The absence of disease model. You're doing a good job in health promotion if you're preventing disease. And it's interesting that people talk about what do they talk about? Prevention and promotion, and it's as if what we're preventing is health. It's just a little bit of shorthand. But as we've seen, the biomedical model is pretty much about eliminating or controlling disease and or disability. So the way health problems are defined is in terms of disease categories that they fit into. Now, the implication of that is if there's no category, then the biomedical model doesn't know what to do. And they have what are called diagnostic dilemmas. So is this an actual health problem or not? And one of the classic outcomes of that is people being reluctant to work with somebody or work around an issue because there's no billing associated with it. There's no item number that people can bill to because there's no diagnostic code. That would be where there's an example would be where there's a complicated case. So we don't actually know what we're dealing with, or there's no overall agreement about what we're dealing with, or back in the day, where there was a need for interdisciplinary consultation, they brought in case conference item numbers so the doctors could attend and get paid for it. Yeah, it's very bureaucratic. Yeah. So for example, cardiovascular disease, AIDS, diabetes, all of these have been and are the focus of health promotion activities. And one of those might pique your interest and be something that you want to look into a little further over the coming weeks. Principal strategies for health promotion following the medical approach. Surgical. Doesn't sound very health promoting. Drug therapies. Give people a pill. Good example of that, statins. Somebody with high cholesterol, borderline high cholesterol, they will give them a statin drug to prevent them developing hyperlipidemia to problematic levels. Okay, so it's looking at a disease process and preventing that illness getting worse. It's not health prevention and promotion. That's what I was trying to say before. It's illness prevention and health promotion. Managed or medically managed health behavior change. This is where people get into trouble because as we've seen, change doesn't happen because a medical authority tells people it should happen. Who's ever been on a diet? Who's ever been on a diet that worked? Who's ever been on a diet that worked because a doctor told you to go on it? No, doesn't happen. Motivation has to come from the inside. Exercise programs, similar. You don't engage in health promoting activities because somebody tells you your health might be at risk if you don't. It just doesn't happen. And please don't write in your assignment that it does. Screening for physiological and genetic risk factors. Interesting, on the news this morning on the way in, they're doing they're recruiting for a big new study on the genetic causality of depression, and asking people to participate and give a DNA swab, a cheek swab, just so they've got a better idea of the genetic background to various aspects of depression. Good one. The target for health promotion following the medical approach is high-risk individuals. You'll see how this plays out once we've gone through the general concept. The general approach is an individualized one, sometimes criticised as blaming the victim, which is essentially a sociological concept that says that if an individual has a problem, then it's the individual's fault for having a problem, particularly if the disorder or the problem can be ascribed to individual behaviours. There you won't go there. The people involved, generally professionals. Physicians, doctors, nurses, allied health workers, consumers, fairly passive in the whole process. If you look at the behavioural approach, lifestyle or public health concepts, health is seen as slightly different. And this should echo for you back from week 1, where we talked about what health is in the first place. Health being an ability to fulfill your functions in society, get on with things, lifestyles that are disease preventing. And health problems are defined in terms of risk factors. And what's the opposite of a risk factor? A protective factor. So something that either places people at risk or protects against various health issues. So smoking, we know, is a risk factor for a lot of health problems, poor eating habits. All of these are associated with poorer health outcomes. Not necessarily with the development of any one particular diagnostic category of disease, but just a general sense of poorer health. So in a behavioural approach, you're more focused around health education, around things like social marketing, around public policies, advocating for smoke-free areas. Any of you remember when smoking was allowed inside? Yeah, it's been a while. It's been a little while. We're showing our age. There's still some countries where it's quite surprising. Okay. Or you'll go to you'll see a video of an old sporting match, and you'll see the smoke cloud wafting across the ground. It's interesting the way fat has been treated over the years. Good fats, bad fats, trans fats, saturated fats, polyunsaturated fats. People get very, very confused and emotional about fat. And I think we still don't know. I mean, the latest is an article I read a couple of weeks ago that all fat may not be bad. I mean, Really? It's a naturally occurring substance. Your brain is mostly fat. So this is not a surprise, or should not be. Yeah, things like bicycle paths, restricting advertising, according to our age group, so forth. The target, again, is high-risk groups, but also people who can do something about it and maybe have bang for buck in terms of younger people. You look after the health of younger people, they're going to be healthier for longer than if you look after the health of older people. It's not that looking after the health of older people is not important, but there's more payoff long-term for society looking after the health of youth and children. The general approaches tend to, again, to be individualised, but with a societal focus in terms of their relation to government policy. So again, things like smoke-free areas, things like restrictions on drinking ages and 0.05. Okay, these are all health promotion projects that have already been done, obviously. So what you might want to do is put together an amalgam of some of those. Yeah. The actors in a behavioural approach tend to be people that have an influence on public policy. So sometimes you're healthcare professionals, sometimes consumers, but people who are networked, people who are working in public health, working in advocacy, working in government. Okay. Then we have the socio-environmental approach, or the structural approach to health promotion, where health is seen as a positive state marked by connectedness to the important aspects of an individual's life. Feeling in control, having an ability to do things that are important or have meaning. Having structures in the community and society that you're living in that are supportive of healthy development. Does that make sense? Once again, we're looking at risk factors, but we're particularly in the structural approach looking at psychosocial risk factors and some of the structural inequalities that have a big impact on health. And in a minute, we'll look at some of those from the point of view of the World Health Organization and where some of the evidence is. I mean, and I find some of them quite surprising, the extent of evidence that is out there. So this is around, from a strategic point of view, from the sorts of projects that get done in accordance with these ideas about what health promotion is about. Developing action groups, doing some community development, capacity building, building coalitions or alliances around particular issues. So they're bigger picture, they're less individualized. Okay, there's really no one person that's targeted by this, but you might have a township that says, what can we do about the high rates of, sorry to pick on smoking, but it's an easy target. The high rates of smoking amongst our young children. And you wouldn't be talking to any one young person. You'd be putting in place various strategies that change the conditions of the community to enable the change to happen. Now, you might do a number of these things in conjunction with each other. You might do an individual approach and a societal approach and a policy approach. Or you might just do one. That's okay. The important thing is to follow the structure that we went through last week. Okay, I think we've covered all that. Yeah, good to know. Just mentioning briefly our old friend Maslow, his hierarchy of not needs, really. It's about what you're motivated to do, what you need to do in terms of, if this stuff is met, then you're ready to go here. But you're not going to go here if you don't feel safe. You're not going to go for prestige. You're not going to buy a Maserati if you don't have enough food on the table. So your basic needs need to be met before you are motivated to go to the next level, and then self-fulfillment. Maslow himself talked about it being quite a rare occasion that somebody was in a self-actualized state, and part of the misunderstanding has been seeing self-actualization as something that should be happening all the time. It's a big misunderstanding. So this is a way of thinking about where you want to pitch what you do. And I've come a little bit closer because the writing is a little small, but it is up on Brightspace for you. And we'll show you a little, I think I put a video up. I'm not sure that I have. Anyway, we'll get to that. You have upstream approaches, which include things like affordable housing, safe neighbourhoods, fair standards of living, a good environment. You have downstream actions that change behaviours or conditions that are causing stress or poor health already. And they're things like incarceration rates, obesity, homelessness, untreated mental illness, low birth weight. And then you have things in the middle that are maybe indicative of people whose health is at risk or is not as good as it could be, where there's movement going on. I just want to pull up a little piece very quickly. Yeah. Actually found this last night. Just illustrates very quickly, it's only a couple of minutes long, what this is all about. Okay, so going back to what we were talking about, does that help clarify things? So upstream is like building a cliff, building a fence rather, so people don't fall off the cliff. That's an upstream strategy. And you can do that in a health promotion way. That's probably the classic strategy that's used. Some people have already fallen in and need to be rescued. And that's where you'd have rescue teams, or to use the fence and cliff analogy, faster ambulances. That can be seen as health promoting as well. The World Health Organization has looked at this. Yes, I'm going to continue. These will be familiar to you. Now, it may be a little confusing that if you count up these dots, there are less than 10. It doesn't really matter. If you reference that page in Talbot and Verinder, I'll be happy. And I don't really care. It's not a great concern for me whether you're talking about 10 or 9 or 8 or 7 determinants of health and how that onion is chopped up. What I want you to get a sense of is how important the social and economic environment is in determining a person's health outcomes, the impact of the physical environment, as well as a person's individual characteristics and behaviours. And here are some examples. Higher income and social status are linked to better health. Is anybody surprised about that? Nobody should be surprised about that. And the greater the gap between the richest and poorest people, the greater the differences in health. Now, it's interesting what's being talked about this morning in terms of the latest figures on mortgage stress and how there are groups in society, generally older, more established areas of cities, where there's almost a total insulation from any problem in that regard. And there are other people who can least afford $20,000 or $30,000 credit card debts and are taking out payday loans to try and pay them off. That's an inequity right there. Low education levels. You're doing better as tertiary students than somebody who didn't finish year 10. Overall, maybe there might be some outliers at either end, but generally, the better your education, the further you've gone in education, the better you are for health. And we know in an overseas aid sense, one of the best predictors for improved health outcomes in developing countries is the level of education for girls. Not guys so much, because they tend to go off and join armies and get killed, but girls tend to be predictors of improved health outcomes as they become better educated. Safe water and clean air. Last week, I was talking about this with another group of students, and a girl from India basically described Australia as paradise compared to where she grew up. Now, her dad was a GP, or is a GP, so she's doing okay. But she was staggered by the differences in the physical environment between where she'd come from and where she is now. And I don't know if any of you from the subcontinent or from other parts of the world have had a similar experience to that. But yeah, she was adamant that we take a lot of the aspects of our physical environment for granted. Degree of support from families, friends, and community. The importance of customs and traditions, cultural practices, genetics, yes. In terms of the likelihood of certain illnesses coming about. Access and use of services. News over the weekend of a new measles outbreak somewhere in the world that should be preventable. People properly vaccinated. And we know that men and women suffer from different types of diseases at different ages, and there's all sorts of reasons for that, but we can't ignore the impact of gender. There is quite an evidence base for how many are there? It's 10. It may not be the same 10 as what Talbot and Verinder are talking about. This is an interesting one. Again, in the news this morning, there was talk about tightening the regulations around CT scan use with children because of the massively increased risk of cancer for kids that have CT scan and sort of, ionizing radiation treatments. But again, things that you may not think about in terms of a health issue, what the transport is like, housing, waste, industry. We'll go through a couple of these very quickly. Transport. There is evidence for a health impact at a societal level. I always think if something makes the news, it means it's not much of an issue. We hear about road toll. There was an accident in Beveridge this morning or last night. Has anybody ever been in a city with really bad traffic? Yeah, where have you been? Huh? Oh, Westgate. Oh, that's not bad traffic. No, that's not bad traffic. Anybody been in Jakarta or Shanghai? Bangkok? Yeah. Tell me about the traffic in Bangkok. How horrific. How is it worse than the Westgate? Is it organised? Just chaos. Yeah. I mean, there doesn't seem to be any rules. People just sort of go where there's a gap, and regardless of what's, yeah. And no, you've never seen a crash. But you talk to people that live there, and they'll say, "Oh yeah, people get killed every day," and it never makes the news because it's just what happens. You know, dog bites man, not news. If it's rare, people pay attention. Yeah. So accidents, pollution from fossil fuels, severance of communities by large roads, and restriction of children's movements. That occasionally makes the news when there's a new freeway going through. I think we're possibly doing better at that than we used to. Not all of these are negative. Okay, better transport does contribute to economic development. So from a health promotion point of view, if you're improving the transport network, and an example is Hastings. Hastings is an area where if you don't have a car, it is hard to get around, and it is hard to get, I don't know if you've ever tried to get from Hastings to Frankston by public transport, but it takes a while. Or let's go even further. Hastings to the closest hospital, which is in Rosebud, you've got to go through Frankston to do it. So transport is a health issue for good and ill. Food and agriculture, an obvious one, but some of the issues maybe not so obvious and quite extensive. When you think about food and agriculture, everybody needs it. Everyone needs to eat. But things like the advent of factory farming, the mechanising of work that's previously done, plantation agriculture, there's been data suggesting that the nutritional value of agricultural products has declined as factory farming has increased. And there's quite a bit of support for that. The impact of forestry on increase in vector-borne diseases, vectors, yeah. Other things like mosquitoes. Similarly with livestock use, health impacts, there is actually evidence for improved health from sustainable farming practices, including what sort of chemicals are used, what type of energy is used, the maintenance of biodiversity. These all help. Talked about fertiliser use and factory farming and the depletion of soils. The impact of irrigation on water table levels, we see that a lot in Australia. And concerns over groundwater from things like fracking, for example. Food packaging, preservation and safety, the advent of use-by dates. We haven't always had use-by dates. There was one incident in Springvale with I think it was a spring roll, something that somebody got salmonella, and from that, everything had to have a use-by date on it. Who's ever felt brave by eating something that was past its use-by date? A lot of them are just numbers. There are like a broad brush strategy to just to maintain overall safety, but there's wiggle room around those. Household food security, we know about the safe range for temperature control for food storage, and if you're in hospitality, so maybe hospitality should be given this talk, around safe food handling practices, all sorts of things. This is all online. You don't need to do all of this. These are just ideas. Masses of them. Masses of ideas for you. Housing. Improvements in housing are associated with improved mental health and improved general health. So the better the quality of housing stock, the better the health outcomes for a society. There's also evidence that as housing improves, rents go up, which can pull health outcomes back down again. Problems with housing insecurity. Outdoor temperature, the quality of indoor air, not just about rising damp, but often sometimes also to do with the use of toxic building materials. I reckon in new houses, the indoor quality is less healthy than outside. And one of the products that they use is formaldehyde in treated pine. Does that mean you don't buy a new house? I don't know. means spend more time outside. Yeah. It's interesting. Some cultures. Any Italian cultures here? Backgrounds here? No. There are some cultures where people don't sell houses. They hang on to them and give them to their kids. Now, maybe nice to have the cash flow to be able to do that, but that's a sort of multi-generational pattern of thinking about property, and not just, oh, when I get old, I'll sell up and I'll move into a nursing home, and my kids may be homeless, but they'll have a big inheritance. Versus people building estates over generations and having an extended family that provide for each other, I suppose. Put it that way. All right, waste. What we do with waste? I think I mentioned that the biggest illness prevention program in history was the London sewers. Did I mention that? Probably very early on. But there are countries in the world, there are large cities in the world where waste disposal is still basically an open sewer. Where for most of the population, the idea of a toilet in each individual house is still a long way off. And toileting is done communally. Does that sound odd coming from an Australian background? It's just totally different. So we could say, how would it be if we said, okay, here's a community, here's a town, here's a village, and we will talk to Caroma and get them to donate 1,000 toilets and get some plumbers to donate their services to basically get this town set up as a pilot project where it was the only town in its state, say, or in its province, where every house had its own toilet. And then you measure the health outcomes in terms of the rates of cholera and vector-borne diseases. You could do that. You could do a project like that. And because I've thought of it, you probably get a good vote. The transmission of agents of infectious disease, exposure to toxic chemicals. There's evidence for all of these having significant effects on health. Radioactive waste in certain areas, healthcare waste. Again, in India, there was a Union Carbide battery factory that had a fire. People remember that? It was a few years ago now. But the community was, and possibly it still is, unlivable. We have Fukushima in Japan. We have Chernobyl. There's still huge areas of land uninhabitable, and will be for a long, long time. And of course, any of these you can look at in terms of, are these upstream effects on health, or are these downstream effects? Are these worsening something that's already there, or are these things that are creating a problem in the first place because when there's something we could be doing that we're not doing? Don't know why hazards has a double Z there. But there is evidence of health impacts from all of these energy issues. Okay, we've heard about black lung, say, the occupational health effects on energy workers, asbestosis, maybe not so much to do with energy, but certainly to do with industry and urbanisation, as we'll get to. Visual impact. I mean, wind farms are so ugly, aren't they? Shouldn't surprise anyone to hear that industry has an effect on health, various aspects of industry. Some worse than others. There was a news item a little while ago, maybe a week or two ago, where they'd found a TV screen from one of the big banks in a third world rubbish dump, and people were pulling it apart for the heavy metals because they're valuable and could be sold, but it should never have been there. Now, heavy metals, alongside being valuable, are also, in a lot of cases, incredibly dangerous and carcinogenic. So there are massive health risks associated with that, and it's why the dumping of those products is restricted, and it's why we have things like recycling bins for mobile phones, because they're full of heavy metals. That's how they work. We talked about asbestos. Most chemicals have particular methods that they have to be disposed of. In Australia, you'll have council collections for even paints, and not even lead-based paints. Not always the case in everywhere you go. One of the things you can do is look at a health regulation that is in practice in Australia, find a country where it is not the case. That's. Does it say that? I don't remember reading that it has to. I don't remember writing that it has to be in Australia. I could be wrong. Look, I'm happy to be corrected on that. Yeah. But even within Australia, you could go rural and remote. So you could look at an Aboriginal population. Yeah. Yeah. Pesticides, paints, and pharmaceuticals. Interesting data that's well known now. Girls getting their period earlier because and part of the reason for that seems to be metabolites from the contraceptive pill in the drinking water. Along with other things. Some of these go back a long way. And the effect of urbanisation has been shown to have demonstrated health outcomes for good or for bad. Anybody spent any time in the country over a prolonged period? No? No, camping doesn't count. Has anybody ever lived in the country? Melton? Do you think it counts as a country? Okay. All right. So the contrast between North Fitzroy and Melton, which one felt healthier to you?
I have more access to things in North Fitzroy. Mm-hmm.
Yeah. So there's a balance there, isn't there? And they're the two big things. There's the access to services and the general environment. One is healthier in the country. The other one you've got better resources to look after things if they go wrong in the country, in the city. Yeah, and that's what the data set tells us. So you could write, around any of these, pick out a detail from any of those, you could write your project. Now, I know there's still a lot of choice, and maybe you're feeling a little spoiled for choice, but there's plenty of possibilities for you. Which one? That one? So, just finishing off, looking at some interventions that you might want to look at. It's a good idea to have a mix of interventions at both an individual and a population level. What you're wanting to do is look at what are the outcomes. Remember, go back to your health promotion plan. What are your goals? What are you trying to achieve? There will be implications of what you are trying to achieve for individuals, but possibly also for groups, communities, and populations. And capacity building strategies are around skills and organisational support. There is a spectrum of interventions that's referred to in the literature. DHS categorise health promotion interventions to form this spectrum, which is basically you have at the upstream level, you have screening, individual risk assessments, immunisations. Moving downstream, we have social marketing, health information, through to health education and skill development, community action, and then when illness is needing to be prevented rather than health promoted as a priority, what are the settings of healthcare? How supportive are the environments? Okay, can you see how that works? Here's some examples just to finish off with some classic health promotion interventions. Very busy infographic about alcohol, but you can find it easily enough. It's on the Victorian government website, Department of Health. So I've got it in PDF if anybody wants it. It's up on Brightspace as a PDF, separately to the PowerPoint slide. And for some people, maybe being bombarded with all that information may change behaviour. I don't know. Not really sure what the effectiveness of infographics has been demonstrated to be, or if they have one. Our old friend, the BMI, bit of a blunt instrument. If you're over 30, you need to lose weight. I always think it's curious that there's no waiting for age in these. That as you age, your metabolism naturally slows, but that's not factored into your BMI calculations. Your risk of weight-related health problems goes up as you age as well. But I wonder whether there's an optimal age ceiling for applying the BMI.
Apparently I should be 54 kilos. I don't ever see that happen. Not since I was like.
Yeah, yeah. So, I mean, this is nice, but for a lot of people, it's a pipe dream. All right. Looking at, picking on smoking again, I'm sorry. Going from the individual to the population level, you can have brief interventions. And advice. You can have community-based health promotion and social marketing. You can have policy and legislation, such as smoke-free areas and restricting access to purchasing. And that's over and above whatever you do with quit campaigns at an individual level.
But presumably going ahead with that thing where anyone born over the year 2000 almost years or there's something to do with year 2000 and born that year. And they had like even more severe restrictions to buy cigarettes than
Yeah, it rings a vague bell. I don't think it went anywhere. Yeah. Another essentially a bit of an infographic, and I mean anybody who's a smoker has had a gut full of pictures like this, and yeah, I know, but it's not that easy. Exactly. And there's another one. But again, yeah, you have a lot of knowledge. Doesn't actually help. And I don't know that I've ever met a smoker who didn't know that what they were doing was not good for their health. Didn't stop them doing it. They knew it wasn't good for them. So generally, looking at the policy frameworks, we have a lot of evidence for what is a good idea, what affects health, what practices might help. We have the current policy and practice frameworks, and overlapping to some degree are the two. And what we're wanting to do over time, what needs to happen over time, is to increase the use of the evidence in policy and practice. And frankly, what happens currently is patchy. We're probably doing better than we used to do. But if you look at what happens in other countries, some places are doing better than us. Some places we're doing better than them. It's not a competition.
sorry, I didn't get that.
Just to finish off with the drum roll. Do you like my drum roll? This is my big finish. Couple of pieces from the Ottawa Charter. Health promotion is the process of enabling people to increase control over and to improve their health. From Vic Health, the Victorian Health Promotion Foundation. Health promotion involves the facilitation of skills in individuals and change in environments that impact positively on health. And from the CEO of the DHCS, it's everybody's business, because everybody has a health status, good or bad, debt and taxes. Let's be honest about, you know, how fundamental this is. All right. That's enough for me.